Welcome to the most impactful week in the movement to end prostate cancer. We're so glad you're here. This event is about you and connecting with experts, advocates, and communities from across the country. Together, we are Zero Strong. Please join us right now for the virtual Zero Prostate Cancer Summit.
Thank you for tuning in to Zero's 2021 Virtual Summit. I'm Shelby Monier, Vice President of Patient Programs and Education here at Zero. First, I'd like to give a special thanks to our sponsor, Progenics, for partnering with Zero on this presentation. Joining me today is Dr. Giuseppe Esposito. Dr. Esposito joins us from Washington, D.C., where he is a professor of radiology and chief of nuclear medicine and PET-CT at the Medstar Georgetown University Hospital. As an expert and researcher with extensive experience in nuclear medicine and molecular imaging, Dr. Esposito is here to teach us more about PSMA PET imaging, a test used to detect prostate cancer. Dr. Esposito, I'd love to thank you for being here with us today.
Hi, Shelby. Thank you so much. Thank you for the introduction, and I'm very happy to be part of this symposium. I'd like to thank Zero for inviting me, and it's my pleasure to speak to the patients with prostate cancer. My presentation is going to be focused on the imaging of prostate cancer with the PSMA PET CT. This is an overview of my presentation. Well, I'm going to firstly be discussing what PSMA is and what is PET CT imaging with PSMA, and how might PSMA PET CT imaging impact the journey of a patient with prostate cancer. How PSMA PET imaging is included in the whole patient management together with other imaging modalities. And finally, I'm going to summarize what we have discussed, but also see how a patient can approach and how a doctor can essentially approach this new imaging modality, the PET-CT, and what are the questions that we want to ask when deciding or trying to decide whether PSMA PET-CT imaging is indicated for a specific patient with prostate cancer. So first of all, I want to make one differentiation between PSA and the prostate-specific antigen, which is what we measure obviously in the blood of the patients to see, to try to decide whether prostate cancer might be present or whether prostate cancer may be recurring after the treatment. So PSA is produced by the prostate cancer, by prostate cells, and is stored into the prostate gland. And so you can see here a kind of a slide of a prostate gland tissue. And the PSA is produced by the prostate cells, and is again stored into the prostate gland, and then is produced and is part of the normal semen. Very little of the PSA goes into the blood in normal conditions. However, when there's prostate cancer, like in this situation, when there's the structure of the prostate gland is disrupted, then more of the PSA goes into the blood, less stays into the gland, but a lot more goes into the blood. And that's why in patient with prostate cancer, the PSA levels go up. And we're able to detect an increase in the PSA levels. Now, PSMA is different. PSMA, if this is a cell and this is a membrane, the membrane of a cell, well, the PSMA would be part of the membrane. So it would be in the cells or in the cell membrane, as you can see here. So this is the PSMA. So a lot less of the PSMA circulates, and again, is expressed on the cells. And that's what we target with our PET-CT imaging. So we target the PSMA. We want to visualize the PSMA on the prostate cells. PSMA is expressed on the normal cells, but particularly in the prostate cancer cells. So this green part here is what we use to attach our radioactive portion. And the radioactive portion is what we use for our imaging. The radioactive activity can be gallium-68 or fluorine-18. These are just different types of radioactive material that we use for our imaging. So PET-CT imaging, what is PET-CT imaging? This is a PET-CT scanner. It's essentially a big detector of radioactivity, and it's attached to the CT to form a PET-CT scanner. So when we inject the PSMA agent, we are detecting the activity, and this is an image of a patient. And that shows the normal distribution of the PSMA. So PSMA is present in the prostate gland, will be present and expressed and visualized in prostate cancer cells, but is also present in the salivary glands. So these are the salivary glands, in the lacrimal glands, in the liver, in the spleen. It's excreted and leaves our body through the kidneys into the urine, and is also expressed, the PSMA, in the small bowel, in the initial parts of the small bowel. So even in normal situations, we will see some activity in the body of a patient. And we have to what's normal and what's abnormal, obviously. As many of you might know already, last month in December, a new agent of gallium-68 PSMA was approved by the FDA for imaging with PET-CT. That's a major breakthrough. And here, what's important, I want to point out what are the indications for the PSMA PET imaging. It's indicated, as per the FDA label, in patients with suspected metastases who are candidates for initial definitive therapy. What does it mean? These are patients that have had their initial diagnosis of prostate cancer, and for which either radiation or prostatectomy are being considered. But we want to be as accurate as we can to see if there is metastasis. Obviously, if there are metastases, the treatment might change and the definitive treatment might not be possible. So things might have to be changed. But because PSMA PET-CT is more accurate, has been shown to be more accurate than other imaging modalities to see where the tumor is, that's why we want to have the better imaging technique to see where the tumor is. So in patients with suspected metastasis, and that means patients that have prostate cancer, which is at higher risk of having metastasis, then those patients we want to have in that initial evaluation, in that initial staging, PSMA PET-CT is helpful. Also, different settings, but in patients that have had initial treatment for prostate cancer, and now there is suspicion that the tumor is coming back, or that has not been completely treated by initial treatment, and that is because the PSA is increasing, then those patients, if there's again indication for retreatment, again PSMA PET-CT, because it's a very accurate technique, again would be best used to localize the tumor to see where that recurrence is coming from. So I'm going to first start with the scenario where, again, it's a patient with new diagnosis of prostate cancer, and the prostate cancer is intermediate to high risk. How does PSMA PET fit in with other imaging modality and the evaluation of the patient is in general? So I want to show you first an image of what difference can a PSMA PET-CT make. So here you can see this is a CT image. So we are at a level of the pelvis. These are the pelvic bones, and the CT shows normal findings, nothing really abnormal on the CT. But when we added information to PSMA PET-CT, so this is that CT together with the information of the PET, you can see that there's a focus of abnormal activity in the right iliac bone, and that's positive, and that's positive for metastasis. So the CT did not see that metastasis. PSMA PET saw that metastasis. And then we compare this also with the bone scan. Some of you may have seen a bone scan image. And then on the bone image, in the SPECT CT of the bone scan, again, that lesion is not seen. So again, that adds value, that adds accuracy to the information that's given to the CT of the bone scan. So it increases the accuracy of localizing the disease. This is another case, again, from the literature, and the CT image shows a very small lymph node here. This is the sacrum, just anterior to the sacrum, there's a very small lymph node. That size of that lymph node is normal by CT. But when we added information of a PET, we see that that lymph node is actually positive on PET, and that's most likely lymph node metastasis. So this patient that by CT did not have any disease, now they are marked in red here at a number of lymph nodes actually they were metastatic. So again, PSMA PET adds accuracy to the evaluation of this patient. This is the patient again that had the initial evaluation, and again that may change the treatment of the patient. This was an important study from Australia, several studies on PSMA PET-CT, but this one showed the results of several patients that were studied with, evaluated with CT bone scan, but also with the PSMA PET-CT. And what the study showed is that whether it's for any metastatic disease or for metastatic disease localized to the pelvis, to pelvic lymph nodes, or for this metastasis, the PET, which are these red dots, showed greater accuracy. Here you can see them all to the right, which is greater accuracy compared to the blue dots, which are CT and or bone scan. And also the sensitivity, so the ability to see the disease, which was much greater for PSMA PET compared to the CT or bone scan. So again, adds accuracy to what the CT or the bone scan see. The same study showed also that the number of equivocal findings are fewer with PSMA PET-CT than with CT. And these are the number, the percentage of equivocal finding. So those findings where we see something but we're not really sure if that's metastasis, if that's tumor or not. And you can see the red dots here for PSMA PET, there were fewer equivocal findings, whether for metastatic, any type of metastasis, whether it's metastasis in the pelvis, localized in the pelvis, or metastasis more distant here. So the number of equivocal findings, again, when we see something, we are more certain whether that represents tumor or not with PSMA PET-CT compared to a CT or a bone scan. And the same study, again, showed another interesting finding, which is very, very important, that when we use PSMA PET-CT, again, there's a change in the management of the patients, which is more substantial compared to the CT or bone scan imaging. And then obviously, and that's kind of obvious because the PET-CT having more accuracy, again, is able to see findings with greater certainty, and so changes management are more frequent because of that. Another interesting finding by this study is that the exposure to radiation is less in patients that underwent PSMA PET than with other imaging modalities. And that is probably because when you have a study that's an imaging modality or technique that's more accurate with fewer equivocal findings, then you need fewer imaging tests. Probably when a patient has a CT or bone scan, they needed a combination of CT and bone scan, or they needed more repeated CT or repeated bone scan to finally have a more definitive result. With a more accurate technique like PSMA PET-CT, probably there's a less need for repeated imaging. We can switch now to another situation. The second situation was approved by the FDA. So that's again the situation where the patient has been treated for prostate cancer. And now we're evaluating, it's being evaluated for possible recurrence of the cancer, most likely because the PSA is going up after the treatment. And also how PSMA PET-CT is included into the evaluation of PET of the patients with prostate cancer. So this is very busy slide, but what shows is there a number of studies, several tens of studies here. They've looked at PET agents to evaluate disease recurrence in patients with prostate cancer. Different tracers with the fluorocholine or PSMA, gallium-68 PSMA PET, or flucyclovine. What's important here is that these are the number of lesions they were able to detect depending on the PSA level. So I tried to summarize all these findings in this slide. And what this slide shows, well, first of all, these are the percentage of the lesions that were able to be seen, identified by PET imaging. So the first piece of information, which I think it's important to know, is that obviously the lower the PSA, the less tumor there is. And so our study, even if it's very accurate, is less accurate than if the PSA is higher. So with, for example, for PSA of less than 1, in red here, orange, or the PSMA PET imaging, so you can see for the PSA level less than 1, if a PET CT is done, there's a 50% probability of finding a lesion at that point. Obviously, the probability increases with the level of PSA. So if PSA now is greater than 1, between 1 and 2, then the probability is going to be greater than 70%. If PSA is greater than 2, the probability is going to be close to 90%. And throughout the range of PSA levels, you can see the PSMA PET is more accurate, or at least detects more lesions than flucyclovine PET or collagen PET. So very accurate imaging, but obviously the accuracy increases with the size of the recurrent tumor. That means with the which is the same as higher levels of PSA. And that's something that we have to keep in mind, obviously, as physicians, and of course also the patient, when we decide to do a PSMA PET. This study showed included patients that had conventional imaging, so CT or bone scan, in patients with recurrent prostate cancer, suspected recurrent prostate cancer, but conventional imaging was negative. About 200 patients. In what the study showed, that by including or doing PSMA PET, the gallium-68 PET, the tumor was actually seen, again, was not seen by conventional imaging, but was seen by PET in 196 of these patients. So the vast majority of these patients, PET CT was able to see the tumor. In about 44% of these, the tumor was localized to the pelvis, whether in the prostate gland or in lymph nodes near the prostate gland in the pelvis. In about 50, a little bit over half of these patients, the disease was instead had more distant metastasis, so metastasis to the bones, to the spine, or to other bones, or to the lungs, the liver, so more distant metastasis. Again, that's very, very important information to decide what treatment to do for these patients. Is a very different scenario where the tumor is localized, the recurrence is in the prostate, or is in lymph nodes near the prostate and the pelvis, or whether the disease is now actually spread more distantly. Obviously, the ability to see whether the tumor that has recurred is localized or has more distant spread is very important for, again, what type of treatment is going to be done in the past. So this study showed, it's a very complicated slide, but in the different scenario, what is initial staging, or what is restaging for patients that are on androgen deprivation, or what is restaging, so reassessment after radiation therapy or after surgery, or restaging after the patient is already a known advanced disease. Well, say the PSMA PET CT is able to see the disease, to change the stage of the disease that was initially suspected in about 69% of the patients. In upstage, so that meant that the tumor was proven then by PET to be more extensive than initially thought in 38% of patients. Downstage, so it was actually proven to be less extensive than initially thought in 31% of the patients. And overall, there was a change in management of about half for the patients. For example, if we look at these patients that had prior radiation therapy, if PET is done, so these are the patients where there was no change in management. But for example, this orange one or yellow is a number of patients, which is about 20% of the patients, where the change was from an initial planned systemic treatment to a focal treatment, to a more localized treatment. So that means these patients initially by CT or bone scanning were thought to have more advanced disease that it was actually proven to be by PET-CT. So that changed the management from like a systemic treatment like chemotherapy to a more local treatment, maybe localized radiation therapy. And the opposite could happen. So it could happen then, the change is from a more localized treatment, then now the PET shows a more extensive disease, and so it changed to systemic treatment like chemotherapy. But again, all this to say that the PSMA PET-CT, because of its high accuracy, allows us to better define what treatment that patient needs to have, and more targeted treatment. So if we step back again and we look at the scenario where the patient has initial diagnosis of prostate cancer, should PSMA PET be done for all those patients? So the answer is no, because again, we've seen how when the disease is very limited, the ability of the technique to see the disease is lower. But not only that, but if the disease, the risk of the disease or having metastasis is very low, then really imaging is not needed. It's not going to add any significant information, most likely. It's probably just going to add a cost and radiation exposure to the patient. So in the initial evaluation of patient, we just had the diagnosis of prostate cancer. If the risk of having metastasis is very low, no imaging is needed. But for all other situations, where the risk is intermediate, high, or very high, then the additional PSMA PET-CT is probably helpful. Again, these are what the guidelines currently say, but the PSMA PET-CT was just recently approved by the FDA, so they're not really included yet in these guidelines. But if the disease, the prostate cancer, the risk is intermediate to high to very high, again, the imaging it would be pelvic or abdominal imaging, it could be CT or MRI in the bone scan, if there is greater than 10% probability of having metastasis. But again, I would add PSMA PET-CT in all these situations for the initial evaluation of these patients. This is the scenario. Again, these are guidelines, the NCCN guidelines, some of the guidelines that we use. But in a patient who's had prior treatment, radical prostatectomy in this case, but PSA is increasing, suggesting persistence or recurrence to the tumor, again, the addition of the PSMA PET helps better define in the tumor where the tumor is. You see that PET is already included the cyclovin or flucyclovin or choline or flucyclovin PET-CT, but definitely we need to add the PSMA PET-CT because of its higher accuracy. And that better accuracy will allow the clinician to better decide whether the patient will have to have radiation treatment, localized radiation treatment, or systemic treatment like chemotherapy, because the tumor has metastasized to more distant location. Similar for patients, a similar scenario for patients who have had radiation therapy and now they suspect a recurrence. Again, PSMA PET-CT will allow us to better decide whether the patient can have radiation treatment, for example, for a tumor that is still localized, and better direct that radiation treatment versus a patient that has now more extensive disease and need to have a systemic disease, like, for example, chemotherapy. What I want also to mention is that not all prostate cancers are the same, obviously, and also within the same patient, not all the metastatic lesions are the same. So some tumors will express more PSMA, will have more PSMA on the membranes, and even within the same patient, some lesions will have more, some lesions will have less. So we always need, again, integration of different imaging modalities, PET-CT or CT, or sometimes also the bone scan. And so this slide, that's what this slide shows. There are some lesions that have low level activity, as opposed to other lesions that have high level of activity. So the dark lesions, more expression of PSMA. This was seen in animal models, again, with that the PSMA expression can be low, but could be very, very high. Most of the times it's high expression. So I'm going to show you some cases that prove how integrating or using all the imaging modalities that we can is important if needed, obviously. So this is a patient, this is a bone scan, and you see this is the spine, and there are several spots here in the spine that tell us that there is metastatic disease in the spine of this patient. And this is the CT image that shows this little white dot, which is a sclerotic lesion in the lumbar spine. And this white dot, however, does not have abnormal activity on the PSMA PET. So sometimes that can happen. Some of the bone lesions, some sclerotic bone lesions may be positive on scan and negative on PET. It doesn't happen that often. Again, the accuracy of PSMA PET is thought to be higher than the bone scan in general. But again, not all lesions are the same, and some lesions may not have high expression PSMA. So the utilization of the different techniques is important. This one was a case in our institution. Again, this is a patient. They had a PSMA PET here on the left side in the MRI. The MRI showed this darker lesion on the left side of the prostate gland, and very suspicion for prostate cancer. And you can see that there is higher activity on the left side of the prostate gland, also on the PSMA PET. So the PET confirms and adds certainty to the fact that this lesion is a cancer. But what also told us with greater accuracy, there were no other lesions elsewhere in the pelvis, or no other metastatic lesions. So that's helpful information, added information. This was a case, again, with an MRI, showing findings on the MRI, where there was a question of it. Okay, you can see here this darker area on the left side of the prostate gland. Questionable, probably negative on the MRI, although uncertain. And we added information of the PSMA PET. We can see that there's a clear focus of increased activity. This shows that there is tumor there, and no other metastasis. So again, that helpful information, because adds to the information in MRI and adds certainty. The other way around sometimes is possible. So we have findings on a PET that are questionable, and the MRI, adding the MRI, helps us differentiate whether that's truly cancer or not. So again, integration of those techniques sometimes is helpful. Another case where there's a questionable finding on MRI, and we added information on PSMA PET, and there were no abnormalities there, further convincing us that there was no residual tumor there. So again, integration of the two is helpful. This is one of the examples where the findings again is the two techniques are in agreement. There is a CT-based lesion here, a wide lesion, a sclerotic lesion with very high activity on the PET. So they both agree. And also there's a lymph node here that is very positive on PET. So again, the PET tells us there is bone metastasis, but also lymph node metastasis. One thing that I want to mention that you will probably see in the reports is that sometimes, as I've shown you from the very beginning, there are some areas that show normally expression PSMA and activity on the PET. And in some of these sometimes we see lesions that have PSMA PET activity, but they're actually not malignant. So this study showed that bone lesions or lymph nodes or some neural ganglia sometimes can have a PSMA PET, but they're benign lesions. And these are some examples here. This is a patient that has, this is the rectum, this is where the prostate gland would be. This small focus, I know this is kind of a small slide, but there's a lymph node here that's positive, so that's metastasis. But there's also another lesion here in the rib that's positive on PET, but that lesion was actually benign, and that would have changed significantly the stage of the disease. So we have to be aware of these false positive lesions that you can see here. These are like ganglia near the spine. They can have activity on the PET. We all know about these situations, but these were not true disease. As well as this lymph node here is a left inguinal lymph node. This lymph node has activity on the PET, but when we look at the CT, the lymph node appears not enlarged, very normal looking on a CT. So that tells us that lymph node is not tumor, is probably an inflammatory lymph node, as well as this one, for example, in the rib is a benign lesion. So the integration of the imaging, the techniques it makes us more accurate and more confident in our findings. Again, and sometimes we may describe in our report some uptake in PSMA that is not related to tumor. This is another example of a patient has Paget's disease, which is a benign condition of the bones that has activity on a PET, but again, it's a benign lesion. And this is rectal activity here. It's just benign finding, just normal activity in the rectum. We just need to work our way out of these findings. So I hope I have been able to tell you all a little bit about PSMA, what the value of PSMA PET imaging is, and when it should be utilized. Overall, again, the PSMA PET-CT is more accurate compared to other imaging modalities for the initial staging of the patients that have higher risk prostate cancer, and for the evaluation of recurrence of disease, if this is suspected based on the PSA levels. PSMA PET-CT helps also better assess the extent of the disease. It can, because it's more accurate to assess where the tumor is, and how much the tumor is present, can affect patient management. We have to remember, however, that PSMA PET-CT, like many other imaging modalities, involves radiation. So we have to use those imaging modalities when it's really needed. And PET imaging is more costly, more expensive than other imaging modalities, probably on average. We have to be aware there are false positives also possible with PSMA PET-CT imaging. So lesions are benign, and shouldn't be, and could be even if they have an uptake on a PET. So these are something that we have to be aware. As for all imaging modality, PET-CT accuracy increases with a higher risk of disease and with higher PSA levels. And again, PSMA PET-CT should be considered when there is high likelihood of metastatic disease or of tumor recurrence. So when it makes sense, a clinician again should consider PSMA PET-CT imaging when a change in disease stage would affect management of disease. So if the tumor is already known to be widespread, so there are lesions in the pelvis, but also in the bones and some organs, probably the addition of PSMA PET-CT doesn't really help. So if you are a patient with prostate cancer and you're discussing with your doctor your management, your evaluation, and if you're wondering whether your PSMA PET-CT is indicated for you, can add value to the management of your cancer, then these are things that I would discuss with your doctor. I would ask, if you're in a situation where it's initial disease evaluation, I would ask your doctor, what is the risk of my tumor to have metastasized? And if the risk is high, intermediate to high, definitely PSMA PET-CT is something that can help in the management of the disease. I would again ask if a change in the disease, in the stage of the disease, would change the management of your tumor. And if a more accurate localization of the tumor by PSMA PET-CT can help better target the treatment of disease. So for example, if radiation treatment is being considered, again, potentially PSMA PET-CT can help direct the radiation to the areas where the tumor is. If you instead are at the level of disease recurrence, so you have the initial treatment, now there's suspected recurrent disease, maybe because your PSA levels are going up. So the question will be, has the site the sites of the disease where the tumor is now recurring, have been identified already? And you've seen how the tumor can be detected when the PSA levels are less than 1 or 1.2. That's very early in the after the disease, for the disease recurrence to be identified. But PSMA PET-CT can potentially do that. So can earlier localization of the disease affect my treatment, change what I'm going to have as treatment? And would a more accurate localization of the sites and the number of lesions change my treatment? You've seen how many patients, about 50% of the patients by one of the study, had change in the management because of the more accurate technique. Now, again, if the tumor is already spread to the bones, to the lungs, for example, so if already this metastasis, probably adding a study that has more accurate identification of the lesions is not going to change the way your cancer is going to be managed. But if it's not that situation, again, and there's potential for change in management of the cancer, then PSMA PET may be indicated.
Thank you, Dr. Esposito. That was amazing and so informative on this new FDA approval. We're so glad that you were able to join us today and share on this important topic. As we truly appreciate your involvement in our summit, again, we just want to thank you for volunteering your precious time for this update. And also would like to have a special thanks to our sponsor, Progenics, for making this valuable content available. For more information on additional topics, please visit our website at zerocancer.org.
Well, thank you so much, Shelby, and thank you to Zero for again inviting me. It was my pleasure. Thank you.
The issues you care about most are right here at the virtual Zero Prostate Cancer Summit. Please check out the other topics, sessions, and virtual get-togethers in your Summit app. Remember, you are not alone. Join the Zero community to gain support and more information on prostate cancer at zerocancer.org.